And then finally, I want to wrap up with an important perspective piece and what does this all mean. This is actually an important study published 23 years ago where patients with advanced lung cancer had 4 different kinds of chemotherapy regimen. And if you look at the survival in about a 3-year mark, very few patients survived, and none of the chemotherapies made a difference. And that's how we were. And then this is the time when we had these kind of a cell phones and this kind of a computers. We moved on. Life has moved on. And now we have, if you look at lung cancer in a 20-year period, there are so many different targeted therapies. We don't treat lung cancer as one group. And if you go back at that time when I showed you those overlapping curves from chemotherapy, we didn't make any distinction. We made a diagnosis of lung cancer from a pathology diagnosis. That's it. We didn't do gene sequencing. We didn't do any of those tests. We just gave them chemotherapy. Now we map the genes. We customize therapy based on these things. And then we are also giving now various different forms of immunotherapy, not just the drugs like pembrolizumab, nivolumab, or tezolizumab, those kinds of drugs. We do beyond that. We now do the bispecific antibody therapies. We are beginning with T-cell engagers. We are CAR T therapies. So this research is ongoing. Obviously, this is more mature in blood cancers. Solid tumors like lung cancer are a little behind because of challenges in getting into the tissues and other issues. But we are making progress. In small cell, we already have an approved drug with the bispecific antibody therapy and targeting the DLL3 protein. And so we're making progress here. And then a question that's often asked my patients, is this lung cancer inherited? My kids get this lung cancer? So we asked this question in the Cancer Genome Atlas project, over 10,000 patients, all kinds of cancers. We asked a question, how many of them are born with defective genes that probably put them at high risk for any kind of cancer? The answer was 8%. 8% of cancers of various kinds had some kind of predisposition that they were born with. And in lung cancer, we've been studying this for quite some time. It's about 4 to 5%. And it didn't really matter whether you're a smoker or non-smoker. Non-smokers are not necessarily born more often with genes that predispose them for lung cancer. And but most of this are random events or some acquired thing that we still don't know much about in non-smokers. So other thing we are trying to figure out is that when patients have lung cancer, they get surgery. Let's say, for example, if you have a stage 1 lung cancer and don't get anything else except just surgery, possibly 70 to 80% are cured on the day of surgery. 20% don't get cured. We don't know who they are. And same with stage 2. If you just get surgery alone, half of them get cured, half of them don't get cured. Stage 3, if you get surgery, maybe 30% get cured, 70% don't get cured. Of course, adding chemotherapy, immune therapy, or in some instances, EGFR inhibitors or ALK inhibitors has improved the cure rate. We still have patients who have cancer come back or relapse after all these therapies, surgery, chemotherapy, immune therapy, or surgery, chemotherapy, targeted therapies of some kind. They still get the cancer back. And there are some who will never get the cancer back even after surgery. So can we do a test to identify who is at a risk for getting the cancer back after surgery or after we do some therapies? So we are now studying the tumor samples, looking at all the genes, all the proteins, and in a big National Cancer Institute project called Alchemist Project, that work is currently ongoing. Hopefully we'll find some kind of a marker we can do in the clinic at some point. We're still about 4 or 5 years away from it. If you're successful, we don't know that. We're going to do research on that to see whether we can find the gene that we can go after. In all solid tumors, there is one problem. We study all the primary tumor tissue when it comes to this research. We don't get metastatic tumor sites that often. And there is a big project currently ongoing done in major cancer centers where we take the primary tumor, various metastatic sites to find out how the genes or the proteins get altered when they go to different sites so that we can come up with better therapies to prevent metastatic disease. As you know, patients do poorly because of 2 things. Cancer metastasizes or the cancer becomes refractory to therapy, oftentimes both. And we have to understand both the processes, and currently those things are ongoing in order to cure this. Of course, no talk is complete unless we talk about artificial intelligence. And these are very, very early days. This is a paper we published a few months ago where we took a patient's primary tumor, lung tumor. We had followed these patients for quite some time. We had over 65 patients. Some went to the brain, some didn't go to the brain. These are early stage lung cancer patients at surgery. We knew exactly whose tumor went to the brain, whose tumors didn't go to the brain. We didn't tell the pathologist. We gave them just a slide like this, what you see here. Asked three expert lung pathologists to predict who do you think did well, who do you think did poorly. Poorly means cancer spreading to the brain. They could have just flipped a coin. Their accuracy rate was like 50%, as you can see here, 55%. But then we actually took these samples, we trained the computer, the machine, what we call machine learning algorithm, the computer, we showed a bunch of slides that went to the brain, bunch of slides from the lung that didn't go to the brain, and then we gave the random samples and then asked the computer, now that it learned AI, to predict. The AI machine the model got it accurate 86, 87% of the times. So does that mean tomorrow you can give the slide to a computer and you can scan this on your iPhone and say this tumor is going to come back somewhere, and more specifically your brain? It may be not at this point, but there is some potential at some point. This is one of the early papers looking at that. Again, just to clarify, these are primary tumors from the lung. The brain metastasis happen in many instances 6 months, 2 years, 3 years after the dissection. But that slide could tell us this tumor could metastasize to the brain or metastasize somewhere else. You know, in this instance, only brain metastasis. So that's what I'm going to focus on here. But the fact that the machine learning algorithm can predict these things, probably they look at how open the cells are and how abnormal the cells are, much more than a human eye can. And or it may be a complete noise and we are looking at something else and this may not pan out. So this is very, very early, not ready for prime time. We have to do more research. But the fact that this can even come this far has given us some encouragement to study these in larger numbers. And we are doing that work currently as we move along. So what do I have to say? This is the best line I can come up with. We have come a long, long way, but we have a long, long way to go. And I know going through lung cancer is not easy. It's very tough and it's harder on the families. And it's a journey that you can only do with a lot of support from your friends, family, and your physicians and their support staff. But I want to reassure you that we are making progress. It's not fast enough for any of us, but we're making progress. I began treating lung cancer patients back in 1998, and compared to that, our patients are living longer, living better. There are more options. I'm optimistic, but we are continuing our work to help all of you. Thank you very much.